Thank you everyone for waiting for the webinar today around how social prescribing can help young people waiting for mental health support. We'll go into the housekeeping rules now as people are just joining. Go to the next slide. Are we okay to go into the next slide, Audrey? Thank you. Yeah, so we're recording this webinar, so you'll be sent the slide and link to the recording, and they'll also be on the NASP website too. If you have any questions for the Q&A at the end, can you submit them through the Q&A function? And then we'll have 15 minutes at the end of the presentation where I'll ask those questions to the panel. There's also the chat function at the bottom where you can introduce yourself and it's for networking. And also if there's any technical issues, just put them in the chat. A member of the NASP team will assist. We have closed captions available. Just turn these on at the bottom of your screen. So there's no BSL interpreters for this webinar. And if you go to the next slide. So I'm Joelle Bradley, I'm Deputy Director for Evidence and Impact here at NASP, and I'll be chairing this webinar. We'll be hearing from Professor Daisy Fancourt at UCL, as well as Dan Hayes at UCL and the Social Biobehavioural Research Group. They're also part of the recently formed partnership that we've developed with UCL on the National Centre for Social Prescribing Data Analysis. And we're also looking to hear as well from one of the social prescribing link workers working on this research, Het Latard. So we'll go over to Daisy first, and thank you.
Thank you so much, Joelle. And it's really wonderful to be presenting to you the findings from what has been over 3 years of study now, considering the role that social prescribing can play for young people on waiting lists within child and adolescent mental health services. This project has been called Wellbeing While Waiting, and it's been very generously funded by the Prudence Trust over this last 3 years. And it's been the first of its kind, actually, thinking about the role that social prescribing plays, not only for young people, but particularly in these challenging settings of child and adolescent mental health services. Next slide, please. The background for the study arose from the fact that we were all very aware about how much child and adolescent mental health services, which are called CAMS, are struggling to meet service demands. So in 2022, there were nearly 1 million children referred in that year alone, and only 1/3 of those actually received any support in that year. 28% were still waiting for support at the end of the year, and 39% had referrals closed before receiving care. So it really is a major problem. And we know there are parts of the country where the waiting list can be months or even sometimes years for young people to access support. And we know that young people on those waiting lists can have a really difficult time. One of the first things that we did with this grant, with the Wellbeing While Waiting grant, was to conduct a study about what it's actually like for young people on those waiting lists. This paper tried to understand how they experience the waiting list process. And we actually found that they report declines in mental and physical health whilst they're waiting. This actually corroborates quantitative evidence that had previously been published, suggesting that 3/4 of young people on the waiting list actually deteriorated. But we also identified that there was social impact, so strain on family dynamics, on relationships, on siblings as well. So this isn't just affecting the individuals themselves. And largely this is driven by some challenges that are systemic within the entire concept of a waiting list in mental health services, including unclear processes and communication, and also a perceived mismatch between the need and support that young people get on those waiting lists. What was quite interesting, though, was when we were conducting this study and we were interviewing lots of young people and their parents, we were asking them what their coping strategies were. And lots of them were talking about the need for various different kinds of resources. But one of the things that came out most strongly was the role that engaging in hobbies was actually providing for young people on the waiting list. And there was this desire coming through in the interviews from young people to have more formalised support with this kind of hobby and community engagement whilst they were waiting. So this really set the scene very nicely for what we have then been carrying out as a study looking at social prescribing in this context. Next slide, please. At the start of the study, we published our protocol for the Wellbeing While Waiting study, which outlined everything that we were planning to do for the research. The aim really was to understand if social prescribing could support young people whilst they're waiting. And so we split the project into 3 phases. The first of which involved co-designing a social prescribing pathway for young people on the waiting lists. So considering actually how will this work in practice, what are the protocols that need to be developed, what are the resources, what training is needed, how could this pathway be delivered, but also manualised so that other places could implement it as well. The second phase was then undertaking what's called a mixed methods hybrid type 2 trial. So what this means is that we were equally interested in the effectiveness in the intervention, but also how it was implemented, like what was the best practice in delivery. And particularly, we're very interested in how these things interact. So what are the ingredients of delivery that could optimize the outcomes for young people? And then the third phase is then considering what the overall potential for scaling the pathway across more CAM sites could be, what implementation models would look like, and also particularly thinking about how we disseminate the findings to stakeholders within policy, research, and practice. So this webinar is one of those activities within phase 3. Next slide, please. For the study, we obviously couldn't work with every child and adolescent mental health service across England, so we decided to work with 11 sites, and we chose these to be as geographically diverse as possible, representing a combination of rural and urban settings, different levels of deprivation, and possibly different kinds of challenges the young people were facing. Next slide, please. We ran our recruitment over a 2-year process from the spring of 23 to the spring of 25, and we recruited 568 young people into the study. So 224 of them formed a control group who didn't receive social prescribing, and then 344 actively received the social prescribing pathway. All the young people had to be between the age of 11 and 18. They had to have capacity to give assent or consent. They had to have been on the waiting list for less than 1 month initially. And initially, we also asked that they would be what's called RAG rated, red, amber, green rated, as green or low amber. Now, this is a way of assessing how severe the needs of the young people are on the waiting lists. So we didn't recruit young people with eating disorders, psychosis, or severe and complex difficulties. However, we actually did see that CAM services changed quite a bit, even in that 2-year setting. We actually started to see hardly any green cases coming through and a lot more amber. So we actually ended up working with a slightly more severe group than we'd originally anticipated. But this, of course, is really important to evolve with how CAMS is working as a service. The control group where it was a smaller group on the waiting list, and they didn't have social prescribing, like I said, but the intervention group did. But both groups took part in the same data collection. So they undertook quantitative scales at baseline, 3 and 6 months follow-up, and they've also been taking part in interviews as well. But before we get into the meat of the research, I want to give you a flavour for what the actual social prescribing delivery looked like. So I'm going to hand over to Het Stattard, who was one of our link workers, to describe what the process actually involved working with the young people and offering them social prescribing.
Hello everyone. Yes, I'm going to talk just a little bit about what it was like delivering social prescribing to our young people on CAM's waiting list as part of the Wellbeing While Waiting project. So first of all, I guess it's important to say that social prescribing is a completely person-centered service. So we work with the child or young person to connect them to activities and opportunities and resources in their community. So on the screen is a word cloud of some of the activities that young people were interested in. And as you can see, it's pretty varied. Football's a big one, animals, of course, but there are also some really niche things. No social prescribing journey was the same. So I became very familiar with the habits of hamsters, Pokemon tournaments, bell ringing, all sorts. It's amazing what young people are interested in, and that's the point of social prescribing. It's not to it's to meet the young person where they are rather than asking them to meet you where you are. So it was very niche and very exciting to kind of find out about all those interests and connect young people to those things in the community. It also involved a lot of community mapping, so trying to figure out what was available to the young person in their communities. In some of our more rural sites, that was a bit tricky, especially in places like Norfolk, where it was very, very spread and services Although there was lots of great things going on, they might not be that close to the young person. So then it was thinking about, okay, if we can't get to that karate club that's actually a 45-minute drive away, what's something that is similar or might make you feel kind of the same as you think karate would, but is a bit closer to your home. Next slide, please. So we delivered social prescribing in 2 different models. And that depended on where we were geographically to the young person. So we did both remote and in-person sessions. For remote sessions, we delivered these on Teams calls, and there were 3 kind of sort of approaches that we took to these sessions. So the first was that sessions, which were about 30 minutes long, could be sort of like creative and fun activities. So that might be something like draw a drawing exercise for 30 minutes, or it might be let's design your dream restaurant's menu. Can we write a creative story together, etc. And all of this was trying to get to know the young person better and get them to know themselves better. And build rapport and trust with the young person, so that when it came to thinking about can we get you into activity in the community, they trusted us as the link workers to find good activities and to try something new. Another approach was kind of mentoring, so thinking about what a goal might be for the young person, and this was really, really varied. So although social prescribing aims to connect people to activities and opportunities in the community, for some young people, it might not be that they're ready to go into the community and do things. So it might have just been, do you know what I've learned about myself is that I am really interested in films, and maybe one day I'd like to try some filmmaking, but my goal for now is just to have figured out about myself. And then finally to think about what was challenging for the young person. So it's all very well knowing that you really want to join a football club, but if you're not feeling confident enough to try something new, then how can we build that confidence? Next slide. And then the other types of sessions were in person. So there were lots of benefits to being in person. One was just getting outside. For some young people on CAM's waiting list, going outside can be really challenging, especially if they're struggling with their mental health and the system inside the home. Their family is kind of worried about their mental health and worried about the young person. Getting outside and going to a park, or just honestly leaving their bedroom, was sometimes really beneficial for the young person. In terms of the sessions, we didn't go into home and we didn't have a sort of venue that we hosted in. So we had sessions in parks, libraries, cafes, maybe even museums and galleries, depending on what the young person preferred. And that was great because it also helped build the confidence of the young person to try new things and make the most of their what's available to them in the community. And then also the great thing about in-person sessions was that we could potentially accompany young people to trying those new activities. So I did a couple of practice bus runs with young people where I met them at their home, and then we travelled on a bus together we went to a Pokemon tournament which was in their local library, and so we practiced doing that. And then it could even be accompanying them to try out the activity, so maybe going to a sixth form open day together, or even getting involved in their first football session. Next slide. So in practice, everybody's social prescribing journey was different. It started with just getting to know the young person and their family with an initial phone call. Then everybody had an introduction session, and that was really just to kind of set the expectations, and that included setting expectations of what we could do and couldn't provide for the young person. And that was especially important given that we're not CAM's clinicians, we're just social prescribers, even though it's a service offered while on the waiting list. And then they had up to 6 sessions. Young people didn't have to use all the sessions if they didn't want to, but we found that almost everybody did. And in those sessions, it was about building rapport, trust, figuring out what's important to the young person, finding an activity, and then potentially connecting with them. We finished everybody's social prescribing journey with a closing letter or an outcomes letter. And this was a really important part of the process because it allowed the young person to really reflect how much they've grown and what they've achieved. And I think importantly, it was about the social prescriber highlighting that even if it wasn't, I've totally recovered from this, or I've tried a new activity, that the young person had grown in their confidence or achieved a different goal. Yeah, happy to take questions at the end, but that's the end of social prescribing practice from me.
Thank you so much, Hat. So the actual participants that we had in this study were very diverse demographically. This is quite a dense table, I know, but just gives a little bit of a flavour of who they were. About 2/3 identified as females and 1/3 as males, 2.4% identified as other. 17.8% of the participants were from minority backgrounds. And we also found that we had particularly good coverage of people from greater backgrounds of greater deprivation. So 1/3 of the participants took free school meals, and 1/3 of them were from the most deprived quintile geographically in terms of area deprivation in the country, compared to just 8% being from the least deprived quintile. We broadly found that the intervention and the control groups shared similar sociodemographic profiles, which is exactly what you would want to see in a study like this, except there was a slightly higher percentage of people from the most deprived areas in the intervention group. So to look at our results, we essentially were trying to see whether there were changes in the outcome measures for the young people between baseline and then 3 and 6 month follow-up. I won't go too much into the statistics of how we did this because we're shortly going to be releasing the paper from this, which will have all of those details on it. But I just wanted to share some of the headline findings from what we've found so far. So next slide, please. As you heard initially, we were looking at young people within the first month of going onto the waiting lists. And there were 2 reasons for this. The first was that we wanted to standardise what their experiences of the waiting list might have been so far. So it was better to concentrate on when they first went onto the waiting list compared to several months down the line for that. But the second reason was we wanted to imagine what the service would look like if it was being delivered nationally. So when people were on the waiting list, what levels were they coming in at? Could they be referred immediately into social prescribing? So as a result, when I show these graphs, it's really showing exactly what the initial baseline results were for these young people in terms of their initial mental health and other outcomes. One of our main primary outcomes is something called SDQ, which is the Strengths and Difficulties Questionnaire. It's a screening questionnaire that's used within CAMHS to look at emotional and behavioural difficulties that young people are facing when they go into CAMHS. And it looks across things like conduct, hyperactivity, peer difficulties, pro-social behaviour. One of the things that we saw quite clearly in this was that there were significant decreases in the intervention group, which is the blue line, whereas the control group essentially stayed the same over the 6-month periods. You can see here that the intervention group started a little bit higher, but actually that was a non-significant difference at baseline. But we found that there was this significant difference in the trajectory that followed over that next 3 and 6 month periods. We then delved into the subscales of the SDQ measure to try and understand exactly which of these were driving the results. And there were 2 in particular. One was conduct difficulties. So young people who were in the social prescribing arm had greater improvements in their conduct difficulties over that 6 months, whereas again, there wasn't really a change in the control group. And the other was pro-social behaviour. So those in the social prescribing arm had improvements in their pro-social behaviour, which relates to their interaction with peers, whereas those in the control group actually deteriorated slightly over that time period. So this is really exciting because this is one of the core measures that get used within CAMHS, and we were seeing this improvement in it as a result of this social prescribing intervention. Next slide, please. We also looked at other kinds of mental health outcomes as well, though. One of the others we looked at is called ARCADS, and it's a validated questionnaire that looks at anxiety and depression in young people. Interestingly, we actually didn't see that there was any significant improvement for the intervention group compared to the control group. We actually saw there were very similar patterns across these 2 groups. And we also, on the next slide, please, saw very similar patterns in terms of stress. Now, one of the interesting things that we actually see across these is that there were improvements in stress, anxiety, and depression from these participants across this time period, which might sound like it's slightly contradictory with what I was saying earlier about deteriorations. But the only thing I would say here is that we weren't seeing any significant changes here. So essentially, these are very, very small fluctuations. They're not actually clinically meaningful changes over that time. So we were essentially seeing that young people were staying at the same kinds of level that they'd come in at. Next slide, please. But another outcome that we saw really interesting results for was resilience. So the resilience scale that we used is called the SRS resilience scale. And it's a measure of resilience in young people that looks across lots of different factors, including their community connections, their participation in community life, their self-esteem, empathy, problem solving, and goals and aspirations. And as you can see, within the first 6 months, the groups were essentially quite similar between the control and social prescribing arm. But between 3 and 6 months, we started to see a really clear divergence between these two groups. And again, this is a really exciting finding because resilience is one of the key things that young people need to navigate the waiting lists, but also then to be able to make the most of their treatment and be most treatment ready. So I'm now going to hand over to Dan Hayes, Dr. Dan Hayes, who has been the lead on this whole trial, who's going to talk you through more of the results from the study, particularly focusing on the qualitative findings, and also consider what the next steps are from here.
Thanks, Daisy. So in addition to the quantitative data, which Daisy has just outlined, we also conducted qualitative data. So there were 2 strands to this. The first was interviewing young people and caregivers about their experiences of waiting for treatment. And then the other was interviewing CAM staff and link workers about their experiences of intervention delivery. We first want to start off with kind of the qualitative findings as they relate to young people and caregivers. Here, what we did is we purposefully sampled young people and their caregivers based off of factors such as the young person's age, the young person's gender, the difficulties they were facing, and their location. And we had 15 young people involved and 17 caregivers. Interestingly, in line with kind of the gaps in previous research, the majority of young people were aged under 14, and most of the research out there currently suggests that social prescribing works with kind of 17 years and above. So this kind of addresses one of those gaps in the literature in terms of how mechanisms may work. There was a range of difficulties involved as we purposefully sampled, but in line with the young people being seen within CAMS, the most kind of common difficulties were around mood. From this, we undertook kind of qualitative, reflexive, thematic analysis. And as you can see from this table, we identified some distinct mechanisms and contextual factors. The mechanisms are outlined in green, and the contextual factors are outlined in orange. You'll see there's a slight difference between the colors in green. So M1 and M2 are slightly darker green. And these were deemed by the research team to be core mechanisms that kind of were found across all of participants, whereas the lighter green ones were mechanisms that were found across quite a few participants, but not necessarily all of them. So in terms of just talking you through some of the findings, I won't dwell on all of them because we'd be here all day. The first kind of core mechanism was around building trusted relationships. And here, building trusted relationships was seen as foundational between the link worker, and that it then enabled kind of engagement with the young person and an ongoing therapeutic benefit. Interestingly, many young people were quite nervous about meeting a professional for the first time. For some, they'd had negative previous experiences of meeting with professionals, and this was also underpinned as well by some of the anxiety they were facing, in part due to their mental health difficulty. However, building these trusted relationships really hinged on the link workers' therapeutic approach, which was underpinned by a non-judgmental stance and a strengths-based approach. And you can see this is really summarized by young person 1 above. So he was asking about, trying to get me out of that bubble, but not being too invasive, just to say, this is your safe space, you can open up. And interestingly, a lot of caregivers were quite surprised on how well their child interacted with the link worker, attributing it to their strong listening and communication skills. And this communication skills, and this was summarized by the parent underneath, who says she just had that connection with him. And that's quite unusual for someone that's just so unfamiliar to connect with him on that. I think it's because she was so interested in what he was saying and actually listening, taking into the details and bringing them up at a later date. Another central mechanism was the involvement in autonomy and agency. And this gave young people, often for the first time, the right to express what was important to them and make decisions about them for themselves. Young people particularly valued having the opportunity to co-create session plans and referrals, but also choose how the social prescribing was delivered. So as Het outlined, there were different models. However, for the ones that were more in London, there was a mix or hybrid approach in some instances. So young people didn't have to meet in person with the link worker every week. It could be every other week, or it could be online. And then following on from that, they then had an active role in decisions about which was important to them for social prescribing and the activities afterwards. In terms of the qualitative findings and the contextual factors about that, some young people, one of the complexities around this was the complexity around severity and needs of the individuals. And this was specifically related to particularly ongoing neurodivergence, trauma, or severe social anxiety. And here, as you can see by the quote from the parent, they were outlining that in some instances, it might be more challenging to work with an individual with these additional complex needs. However, link workers were able to, in most instances, work with these people. However, it required much more accommodation, working with them over a longer period of time, and really adapting the activities to make sure that they were suitable for the individual in question. In addition to kind of the complexity and severity of needs, there was the involvement of caregivers. And this, when they were involved, really was about enhancing the social prescribing by reinforcing the key mechanisms and helping young people develop these healthy coping strategies via these social prescribed activities. When appropriately engaged, caregivers often felt young people were better equipped to support them. And however, conversely, when caregiver involvement was lacking, in certain instances, this meant there were missed opportunities for a young person to be properly involved in social prescribing and helping address these needs. For example, taking the young person to and from the activity when they were far away. Moving on to the qualitative findings from CAN staff and link workers. Now, this is quite a complex slide. I'm not obviously going to go through all of these, but this is just to outline a different approach that we used. So whereas the previous approach used kind of a reflexive thematic analysis, we used a framework approach here, and we used something called the CEFA framework. And this is very much looking about embedding and sustainability of interventions. And this can be done across different factors, such as whether there's innovation, and then what the outer setting factors may be, or the inner setting factors. There's also things related to individuals, what the implementation processes were, and what the outcomes with regards to the innovation may be. Again, we used a purposeful sampling approach here. We interviewed 23 participants consisting of 11 link workers and 12 CAMs. In terms of purposeful sampling, we employed an approach looking at site again, but also the amount of time that they'd been in the link worker service. In addition to this, we also applied the COMBI framework, which is a theoretical framework which looks at barriers across the individual level with regards to capability, opportunity, and motivation. Just touching on a few of these points here. So in terms of innovation, obviously social prescribing with young people is a fairly new approach. However, what we found, even though the results which we've just spoke to you about weren't out yet, was that CAMS clinicians could see the evidence of a social prescribing approach within their service, often tying this into specific techniques such as behavioural activation and motivational interviewing that they knew could work with young people and help them achieve their goals and help them kind of therapeutically. This is very much outlined by the quote at the top, speaking about the evidence base for behavioural activation for depression making a big impact. However, a potential barrier with regards to the implementation of social prescribing was very much around partnerships and financing, reflecting approaches and research elsewhere. Key to good social prescribing approach is the ability of a wide range of community assets to be available, which the link worker can refer young people into. Often in more rural locations, these were more spread out. However, we did find a wide range of community activities as well as online activities that were available. However, this often took more time and involved talking to a lot more young people in order to make this a reality. Then in terms of a few other kind of findings from link workers and CAMHS clinicians, infrastructure was also seen as a really important aspect in order to make social prescribing a reality. Within Wellbeing While Waiting, we employed different approaches. So sometimes the link workers were specifically embedded and part of CAMHS. In other instances, link workers were either remote or part of a third sector organization, which were collaborating with CAMHS. While safeguarding was instrumental in all of these and very well thought out, link workers who were not part of CAMHS but were employed to work via third sector organizations with people on the waiting list often spoke about some of the difficulties around information sharing and data security. This included things such as where to store the records or having to duplicate records on the CAMHS system to make sure it was recorded, given this was a waiting list project, but also within their own systems. However, one way to navigate this we found, which was quite successful, was link workers having honorary contracts. In terms of individual barriers, what we found was that stakeholders and link workers in particular spoke about the need for appropriate referrals, and that actually there were limitations with regards to what they could and could not do with young people on the waiting list. So for example, if a young person had specific questions around their medication or about how to get more mental health support at school, these were things that link workers didn't feel that they were equipped to deal with and wasn't part of their professional role, but still felt that they were stuck with working with this young person and maybe having to avoid having to have these conversations rather than kind of refer back to CAMHS, given that they were already on this waiting list. Lastly, link worker retention was also seen as critical, and this is kind of reflected throughout the wider field, including the link worker survey, which NASP do every year, which is very much around upskilling and retention of link workers and the difficulties with this currently. In particular, good clinical supervision in order to manage link workers' mental health and make sure that they were also supporting young people appropriately was seen as critically important, as well as managing their own capacity, the link workers' own capacity. In terms of wrapping up of the Wellbeing While Waiting kind of findings, this is the first robust study to demonstrate that social prescribing can have a positive impact on mental health difficulties in a more specialist setting, and in particular using a control group to be able to make more strong inferences about the impact of social prescribing. Novel findings in particular include an increase in resilience, which we haven't seen demonstrated in the literature before. And we conclude that this can help, so social prescribing can be an effective tool to help young people with their mental health whilst they wait for treatment. And below is just a picture of a young, by a young person as part of their link worker social prescribing journey. And it says that possibilities are endless. Finally, in terms of kind of the Wellbeing While Waiting slide, our vision is to have a fully developed tested model for embedding social prescribing within CAMHS waiting lists that can be implemented on a national scale. In order to do this, we have already started developing some resources, some of which you may have seen previously. So on the left, we have our practical guide. This was our learning from phase 1, as outlined by Daisy at the beginning, on social prescribing and how to implement it within CAMHS. This gives you an idea of things that could be covered, a step-by-step process and critical considerations. We've also got our trial protocol, which details the evaluation process for recording these things in more detail, should you be interested in that. And we've also got some webinars, the top one being a webinar from our link workers, specifically on what it's like, really kind of going into a deep dive on what Het was talking about before. Lastly, so I suppose this leads to some questions such as where next? So given what we know about social prescribing and CAMHS now, we're really thrilled to say that we are launching some new programs of work. The first is called CASPER, and this is in collaboration with North London NHS Foundation Trust and Norfolk and Suffolk NHS Foundation Trust. And this is a pilot study very much looking at social prescribing as part of a step-down approach once young people have finished mental health treatment, to see if this can stop young people returning to CAMHS by increasing their resilience, and in doing so kind of limit or hopefully not contribute to the ongoing waiting lists. We also have ENACT, which is a social prescribing project via schools, specifically targeting young people who are at risk of loneliness. This follows on from our pilot for ENACT, which we found showed that social prescribing was feasible, acceptable, and suitable within schools. And on the right here, you can see that we've got good geographical coverage of schools all the way from Sunderland through to London as part of the ENACT trial, which we're currently looking at clinical and cost effectiveness of social prescribing in this setting. Lastly, earlier this year, we were successful in obtaining or being able to host the Social Prescribing Youth Network, following on from Street Games hosting it since 2018. This is a network that's free and open to all, and as you can see from the spokes here, involves a lot of different areas that we're currently focusing on. This includes training opportunities, and I'm pleased to say that we, along with NASP, are developing a social prescribing for children and young people training package, which should be out early next year. It also details the latest research, not just within our studies, but the wider field with regards to youth social prescribing. Networking events and opportunities where members can meet up and discuss, troubleshoot, and share resources, as well as opportunities to shape resources and practical resources, some of which have been developed by our social prescribing team, such as the Burger a Day, which you'll be able to see more about on our website. These are just some of the activities that SPIN have been involved in this year. And you'll see we've had kind of our member meetups. We've got resources for social prescribing, as well as the development of our youth advisory group, who are currently just developing evidence briefings along with us and some infographics based on the main trial findings. And we're pleased to announce that we have now finished a program of work along with NASP and the South Bank Centre, focusing on how to embed and sustain youth social prescribing. And this is perspectives from commissioners and policymakers. And this is available via our website now. Lastly, I just wanted to finish with some quotes from a couple of the young people. So the first was a quote from a young person with regards to social prescribing. So my link worker really helped me get back into social prescribing groups and social settings. The group sessions are really fun, and I've been able to make a lot of friends from them. They're a big support in my life, and they've definitely helped, because I can talk to people easier, and just be in the same room. Just being in the same room as a bunch of people is easier. And then from a parent, the people in the team, which I think is the people on the team, which I think is quite a social thing for him, being part of a team and being good enough to be on the team, because my child has always struggled with low self-esteem, and he seems to be quite popular with older kids. So it's about building him up. He's really benefiting from it. Lastly, these are the Wellbeing While Waiting team members. Without the project would not have been possible. This includes our Daisy, who's led the project, Faye, who's our statistician, our coordinators and managers, including Rachel and Nikita, our research fellows and senior research fellows, including Alec, the two Alexes, and Emmeline. And lastly, our research assistants and link workers, including Jolie Wright, India Startard, Lou Stipridge, and Joanna Page. I'll hand back over to you now, Joelle.
Thank you, Dan, and Daisy and Het, for all that information. There's loads of detail there about the quantitative and the qualitative results, and we've had lots of questions coming in. If you have more questions, do add them into the Q&A, and we'll try and get through them. So one of the questions, and a few questions came up, were about the control group and whether they were offered any support at all. Daisy mentioned the control group briefly at the beginning, but I wondered if you could add a bit more information about what happened to those on the control group in terms of whether they offered support later or not.
So the control group weren't offered support. We actually recruited the control group whilst we were developing the social prescribing pathways, so there wasn't any need for randomization. However, given that we were only looking at recruitment within the first month, they did not receive any support other than what was traditionally offered by CAMS. Sometimes this included like a kind of checking call or the direction to some brief psychosocial resources, which would have been available for both the control group and the social prescribing group regardless. So they weren't offered any type of social prescribing longer term, and we did capture all of their kind of service information as part of that.
Thanks. And there's also questions about the reason for the less than 1 month on the waiting list before being offered the support. Was that part of the kind of programme design, or was there a specific reason for that kind of area?
Given how long the CAMS waiting lists are, if we didn't have kind of the 1 month period, we could be recruiting individuals who'd been on the waiting list for 6, 7, 8 months. Actually, one of the sites we worked with had a wait list of nearly a year and a half. So we wanted to make sure that the control group and the intervention group were comparable. So that's why we implemented a 1 month rule. Obviously, as we were also developing the social prescribing pathway, if we made it 2 or 3 months, we'd have to wait longer to capture all of those people at the 3 month mark in the control group to make it comparable to the social prescribing group. So it was kind of a pragmatic reason to make sure that the 2 groups were comparable.
And then there's questions about kind of who else you worked with. So how much did you rely on parents, for example, to transport young people to the activities, or whether you worked with other professionals that are working with young people, like family support workers in schools?
I think Het will be better placed to answer that question.
A bit of a mix to that answer. So often it was really important to work with parents and guardians because yeah, exactly, like giving people lifts. But then sometimes it was also about helping that young person identify who might be a trusted adult to help them. So parents and guardians, but also aunts and uncles, friends, and it was about kind of empowering them to reach out to them, and in some occasions doing some advocacy, like can we speak to the parent or guardian on their behalf. We didn't have very much communication with school, and I think that was a lot to do with our role and where we sat in within CAMS, because we kind of had honorary contracts with CAMS but weren't sort of professionals within within the trusts, and so it was dependent upon the young person, what their connections were like to other professionals and adults, and where it would be like most appropriate for us to slot in.
And there were some questions about, particularly about kind of school experiences. Did you find that a lot of the young people, there were barriers to education with kind of attendance or kind of other kind of issues with education?
Yeah, I mean, I can't speak for all of the social prescribers, and also it's important to say that we had social prescribers working at different sites, so they might have had slightly different experiences, but I think definitely within the UCL social prescribing team, I would say like a significant, the majority of young people were either I really hate the term, but school avoidant, or would struggle to go to school. And yeah, that was a really common experience for the young people that we worked with.
And is that something that changed during the time that you were supporting? Were you able to have much impact on that?
I guess we didn't keep track of that necessarily. And what I would say is that as social prescribers, our job wasn't to get them back into school. And for some of the young people, it was about saying, okay, yeah, sure, maybe school isn't the right thing right now, but maybe getting out of bed and making your bed in the morning could be the right thing. So yeah, I don't know if I could, yeah, I don't have any statistics to back that up, but I think in general, the kind of emotional resilience improvement that we've seen from Wellbeing While Waiting, I wouldn't be surprised if that encouraged young people to be able to think about going back to school.
Thank you. And a common question we get about funding for the activities. Was there funding pot available to fund some of the activities? Was that an issue in terms of the cost for any young people?
So we had a £40 budget for each young person, and we use this for things like buying maybe equipment, like a pair of football boots, or an entry cost or something. And what we would say is that yes, there was definitely a cost barrier to lots of activities for young people, but part of our role as social prescribers was to kind of think creatively about how to get around that. So I don't know if other professionals on this call have found this, but I think often my experience is that if you call an organisation or an activity that does have quite a high cost barrier to taking part, and explain who you're working with and why you want the young person to go to the activity, there's normally a bit of money or a space that they can create for that young person. And then also thinking creatively about, like, one of our colleagues amazingly managed to make somebody's educational health plan pay for some horse riding via like a PE lesson pitch. So yeah, cost barriers was definitely an issue, but there were kind of some workarounds around it. And then the last thing I'd say on that is sometimes our job as a social prescriber is to figure out what's sustainable. So if a young person really wants to do something that maybe costs a lot, like gymnastics, and that there just seems like no financial way we can support them into doing that, then okay, what's a more sustainable activity nearby you that would make you feel as confident as you feel like gymnastics would make you? So maybe there's like a dance class that's low cost or free even, or that kind of thing.
Oh. And another question in terms of the activities as well that you connected people to, was there any kind of screening process or kind of quality assurance of those activities to ensure the kind of quality of experience for young people?
Yeah, so I mean, there's definitely limitations to it, especially if we weren't if it was remote social prescribing with some of our young people maybe in Norfolk, like we couldn't physically go and check out those spaces. But yes, we would never just do a cold handover to an activity for a young person where we're just like, oh, this is the details for this football group or whatever. I know everyone's social prescribing practice is different, but for me, I would definitely at least be doing a phone call, checking that there was some kind of like safeguarding protocol or policy on the activities, like website or available that you find. And then yes, we definitely did our best for quality screening, but yeah, as I say, there's kind of only so much you can do as well. And sometimes it was about the young person going and saying like, I didn't like the activity, and then you saying, amazing, that's great, it's another thing we found out about you, well done for knowing. That's fine for me.
And that feedback, so I don't know how much people would be connected to the same activities, but if you get negative feedback from one person, I suppose you can kind of retain that knowledge and use that going forward.
For sure.
And then there was a question about children with disabilities. I know you talked a bit about young people, neurodiverse young people, and how support may be adapted or was more intense for young people. Were there other disabilities? Is that something that you recorded? And did you notice kind of different needs or different ways to support those with different disabilities?
I'm not sure about the record keeping, maybe Dan can answer to that, but what I would say is that it depended on each social prescriber. So I have personally in my professional career, I've got quite a lot of experience of working with children and young people with disabilities or neurodiverse. So I was very comfortable working with those young people and felt like I had the skill set to. Maybe other social prescribers didn't feel like they had that skill set, but were probably wonderful with other needs that young people had. So I guess it was really dependent on the social prescriber and the young person, but the great thing about social prescribing is that it's person-centered. So it was totally, the experience was totally curated for the young person that the social prescriber was working for. So yes, loads of adaptions and able to like change things to make delivery most accessible for the young person.
We did ask young people and parents to report the young person's difficulties with regards to aspects such as learning difficulties or neurodivergence. There was a chunk of young people, I can't give you the exact figure off the top of my head, but we also got queries from a lot of CAMs with regards to whether young people with neurodivergence would be eligible given what we know, as actually a lot of the young people on their waiting lists were not only receiving or due to receive a psychological intervention, but were also on the waiting lists for a developmental assessment, for example, autism. What we know about neurodevelopmental difficulties such as autism is that often tends to be quite a big overlap with aspects such as anxiety. So providing they were on the waiting list for psychological therapy, that didn't exclude them. So we did get a chunk of individuals with neurodevelopmental needs across that.
And another research question here, this is one we discussed, Dan, but was any data that showed that young people who'd received this social prescribing support while on the waiting list no longer needed to be on the waiting list? And do you have any kind of reflections on that as well?
So we haven't looked at that data yet specifically. That is something that we've been working to get from CAMHS. And we might now have most of the data from CAMHS, but we're just trying to get a complete data set to be able to see if we can make accurate inferences on that. I would say, given the results, I'm not sure we can say either way yet. If the vast majority of the young people were waiting for a psychological treatment for anxiety and depression, and we see that actually those aspects didn't seem to make a difference with regards to those in the social prescribing arm versus the treatment as usual arm, then actually they probably would still be on the waiting list. And also given the fact that these people have been on a waiting list for quite a long period of time, there may be a case to be made that actually they'd still be on the waiting list because that they've been waiting for such a long time for this that they may as well. We will be looking at that data, but it's a bit uncertain at the moment.
Yeah, and it was interesting what Daisy mentioned at the beginning as well about young people tend to deteriorate on the waiting list as well. So yeah, it'd be interesting to see the data on that in more detail. Another question in terms of the link worker support was around kind of co-creating kind of experiences and making choices around activities. I know you talked about some of the creative ways that you were doing that as link workers. Or were there any kind of standout emotions or practical barriers to them being able to make kind of choices, did you find?
Yeah, some young people were quite maybe like a bit overwhelmed by someone sort of saying, so what are you interested in? So I think most of our approaches was very kind of fun and like gentle ways into that. So things that kind of sound silly, but I think can have a really big impact. Like I became very familiar with the plot and interpersonal relationships of the Netflix show Outer Banks for one young person. And then we use that to think about, well, what character are you most like and why? What are the identities and values of that character? Okay, and then thinking about if that's what you know about yourself, what kind of activities could we think about in the community? And then other challenges where there was one young person who like really struggled to engage with me as a professional and as an adult and didn't want to talk or look at me, and then it was all remote sessions. So then what we ended up doing was I would send him a link for a video game, and we'd both play the video game at the same time. I would have one screen with the video game, he'd be on the call on the other screen. He wouldn't look at me at all, he would only look at his computer and play the video game. But while us both playing the video game, I was able to talk to him. And then eventually he decided he wanted to go to a football club, and I was able to find that. And through the whole 6 sessions doing that, he didn't look at me once. But so, yes, there were lots of challenges, and it was really about finding ways to kind of, I guess, almost like make it less like affronting for the young person. Like, what way in can we find to talk about what's important to you?
Oh, thank you. And Dan, it's a question about the vision to roll this out nationally to kind of all CAMHS team. And how do you see this working in practice, whether there's any kind of time frames in terms of that goal?
Yeah, it's a good question. So now the results are out and we're just writing it up into a paper. We're hoping that there will be some uptake from this. I'm happy to say that actually for at least 4 of the CAMHS teams that we worked with as part of Wellbeing While Waiting are still continuing their offer of social prescribing whilst young people wait for treatment. The others not because they are not interested. It's more about sourcing the appropriate link workers, but also making sure that there's the funding arrangements in place now that the study has ended. So there definitely is appetite for this. What we are trying to do is we're currently working with some individuals at the Royal College of Psychiatrists and trying to include some questions on their annual audit to look at how we can see what the uptake of social prescribing on young people waiting for treatment will be. We'll also be kind of trying to monitor and track the downloading of the free resources, such as the implementation guide that I've outlined. And we will be also linking this into our SPIN work more closely now. So we'll probably hold some webinars as part of SPIN, trying to kind of unpick these findings further. But also we'll be holding a symposium in February, which will be both online and in person at the South Bank Centre, kind of tying this in with some of the other strands of work. You'll see on the last slides that we looked at was around kind of the policy brief around embedding and sustaining social prescribing from the practice of policymakers and commissioners. So trying to tie this strand in more closely with the findings of the quantitative and qualitative research from Wellbeing While Waiting.
Thank you, Dan. Just a few more questions, if that's okay, around some practicalities of kind of implementing this, things like insurance and safeguarding. Was that something that you vetted with agencies? Like, how did that work in terms of?
Are you talking about like for us or for the
I think for the things that you were connecting people into, so how to ensure that those activities over safeguarding kind of measures?
Yeah, I think essentially just as best as we could. So I guess it depends a bit for the activity. So whether it was like a website or a contact at the activity. But the kind of specifics that we wanted to know for sure and that we wouldn't make referrals without was that there was safeguarding, up-to-date safeguarding policy in place and a DSL at the activity. Yeah, that was kind of it. And then, yeah, it would just depend on what information we could get. So lots of like emailing and phone calls, and where possible, we would go and visit activities.
Thank you. And then just, I think this is the last question. So in terms of kind of if people are interested in joining this or kind of exploring social prescribing in their area for people on CAMHS waiting lists, do you know how they can be connected to this or what they can?
Are you talking about
So if other new areas are interested in implementing something like this?
Yeah, so for new areas, what I would say is if you join the Social Prescribing Youth Network, we'll be holding more information about that there. So if you just write in SPIN, SPYN, and Social Biobehavioural Group, it will take you there. Our newsletter is free to sign up, and it will give you access to tons of resources, all available at the site. Our members meetups, the next one I believe will be in January, will actually allow lots of different people in different areas to come together. So there'll be kind of policymakers, commissioners, link workers, and forums such as that really help set the scene and connect people to be able to begin to make the steps happen for social prescribing pathway where they are.
Thank you. Thank you very much, both of you, and Daisy. That I know Daisy had to leave earlier, but yeah, thank you so much, and thank you to everyone that's engaged and sent in questions. As I said, we'll send the recording out, and it will be available on the website as well, and the slides will be shared. So do have a look, and yeah, keep watching out for some of the progress that Dan's talked about, and do join the network if you're interested. So thank you very much, and we'll speak soon. Thank you.
Bye.